Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. This episode features content from an educational webinar titled Strategies for Optimal HIV Treatment and Prevention, Monkeypox in People with HIV, featuring Dr. Monica Gandhi and Dr. Chloe Orkin. Dr. Gandhi is a professor of medicine in the Division of HIV, Infectious Diseases, and Global Medicine at the University of California, San Francisco, and the medical director of Ward 86 HIV Clinic at San Francisco General Hospital in San Francisco, California. Dr. Orkin is a professor of HIV at Queen Mary, University of London, and a consultant physician and lead for HIV research at Barts Health NHS Trust at the Royal London Hospital in London, United Kingdom. In this episode, they will answer questions and discuss key considerations for treating monkeypox in people with HIV. For the full online educational program, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Gandhi and Dr. Orkin have to say.
Hello, everybody. It's wonderful to be here, and I'm especially excited to be here with somebody who's been an absolute icon and is an absolute woman in science and legend, and that is my co-faculty, Monica Gandhi, and I'm really happy to be here with her. So what I'm going to do now is I'm going to talk you through some slides and give you a context, and then we're going to open the floor and get you to ask your questions of us. So as I'm sure most of you will have gathered by now, monkeypox was first described in monkeys used for research, and that was a long time ago in 1958. The first human case was in a baby in what was then known as Zaire and is currently the Democratic Republic of Congo. And since then, it's been transmitted to humans largely by infected animals, mainly rodents, in which it's very easy to infect rodents. And there have been chains of transmission based on index cases. And countries in Central and West Africa have experienced outbreaks since the 70s. And upsettingly and alarmingly, these outbreaks have been getting bigger and bigger, certainly in terms of the number of suspected cases that they've been reporting. And in 2017, there was an outbreak in Nigeria, and the senior clinicians felt strongly that sexual transmission may have occurred, and they've subsequently described this and did describe this at the time. So in terms of the monkeypox outbreak currently, there are well over 70,000 infections as of October the 10th, and 97.1% with available data are male. And amongst those with known knowledge of the HIV status, 48.1% in the WHO dataset are people living with HIV. So far, there have been 26 deaths, and more than 180 countries are affected. So what we knew about monkeypox in people with HIV prior to the current multi-country outbreaks was largely based on work that came out of Nigeria on a retrospective review of 40 hospitalized patients with monkeypox in Nigeria. And 9 of these people were people with HIV, 4 were newly diagnosed with low CD4 counts, 5 had previously received treatment. 3 of them had actually, the treatment hadn't worked in first-line treatment, and there were some low CD4 counts there. So compared with people without HIV, what they found is that people with HIV had more prolonged illness, larger lesions, and higher rates of secondary bacterial skin infections and genital ulcers. So they found different outcomes. So early on in the global outbreaks, I was the global senior author for a large international case series on monkeypox, and we described 528 infections between April and June. And what we found is that more than 99% were male and 95% were gay or bisexual men. And we felt that 95% sexual closeness was the suspected route of transmission. And we noted that 41% were people living with HIV. And in our cohort, the CD4 count was very high. It was 680, the median CD4 count. And 97% of people had viral loads less than 200. And we didn't find any differences between people with HIV and without HIV in clinical presentation, frequency of admissions, or disease severity. But the caveat is that we're talking about a very different group of people to what was described in the Nigerian research. So What do we know in terms of what the CDC have reported? Well, what they have reported is that there's an increasing proportion of people with monkeypox amongst Black and Hispanic or Latinx people. And we know that Black and Hispanic Latinx people are disproportionately affected by HIV too. So we are potentially seeing a sort of an enmeshment and an intersection between social determinants of health. CDC data further, what they've reported recently is that people with HIV have been disproportionately affected by monkeypox. And what they found is that only 82% of the people that they were talking about had viral loads less than 200. What they noticed in this group is that 8% of people with HIV were hospitalized versus 3% without HIV. They also noticed differences in clinical presentation, in that people with HIV were more likely to have rectal pain and other rectal manifestations. And therefore, they said that it's really important to prioritize people with HIV and sexually transmitted infections for vaccination. So, what are the treatment recommendations? Well, firstly, one of the most important things is supportive care, and that includes pain management, because these lesions can be extremely painful, especially when they affect the rectal mucosa, or indeed the vaginal mucosa, or indeed the urethra. And it's really important to know, and the mouth, and it's important to know that people have problems with swallowing, problems with defecation, can have bad infections, and pain management is very important. But actual antiviral treatment can be considered in severe disease and involvement of anatomic areas that may result in serious sequelae, and for people that are at high risk for severe disease. And that includes people with advanced or poorly controlled AIDS, who may be immunosuppressed for other reasons. And we need to bear in mind that adverse outcomes from monkeypox have been previously described in pregnant women, which is a relative state of immunodeficiency, and also in terms of the outcomes in terms of the fetus. And also poorer outcomes have been described in children. So in terms of treatments, tecovirimat is approved for smallpox, and it's been authorized in different ways by the EMEA under exceptional circumstances and the FDA under compassionate use for treatment of monkeypox. Cidofovir and brincidofovir, which is a cousin of cidofovir, it also potentially has activity. And then there's vaccinia immunoglobulin intravenously, which can be considered if people are exposed. So in people with HIV, the CDC have advised that in their opinion, of the people with severe manifestations of monkeypox, about whom the CDC has been consulted, the majority have been people with CD4 counts less than 200, and this indicates substantial immunosuppression. So because of this, the CDC recommend that these people should be prioritized for treatments such as tecovirimat and vaccinia immunoglobulin. Furthermore, the wonderful people at the Liverpool Drug Interactions group have added very quickly tecovirimat to their website. And what they have shown us is that the good news is that most drugs are okay. But although things haven't been studied based on the pharmacokinetic properties and the pharmacodynamic properties and what the drug is and how it's metabolized, what they feel is that tecovirimat may in fact affect rilpivirine. That's the orange that you see there. It may decrease rilpivirine concentrations. And therefore, their advice is to increase oral rilpivirine to 50 milligrams. So it's normally dosed at 25 milligrams, should be increased to 50 milligrams daily during co-administration. For people with HIV receiving long-acting cabotegravir and rilpivirine, it's important to consider increasing the dose there too, because you remember for the nanomedicine and the long-acting preparation, the dose will equilibrate to something very similar to 25 milligrams orally, so that may need to be boosted as well. They also advise quite sensibly that if somebody's on tecovirimat, this may not be the best time in the world to initiate cabotegravir or rilpivirine, and I'm sure that everybody can sign up to that message. So moving forward onto vaccine recommendations for people with HIV, it's important to remember with monkeypox that vaccination can be given in two ways. One, as a post-exposure prophylaxis, and then in this instance, it should be ideally given within 4 days of exposure, but up to 14 days it may have efficacy. But it's important to recognize that it may also be helpful to offer PrEP, so pre-exposure vaccination, so to try and prevent monkeypox. So in this situation, there are two different vaccines. There's the Jynneos or Imvanex vaccine. This is the MVA from Bavarian Nordic, and this is a replication deficient modified vaccinia ankara vaccine with an indication for both smallpox and monkeypox. And the recommendations in adults, people with HIV, not previously vaccinated against smallpox, and CD4 counts greater than 200 are that it can be given 0.5 ml subcut or IM, as it was actually identified to do on the label, or it can be given at 0.1 ml intradermally, which is what's actually happening in many countries in the world in order to stretch the amount of vaccine, because actually the intradermal region is very rich with immune cells, and there's very good biological plausibility for this as a strategy. But it's important to remember that in people with HIV, not previously vaccinated against smallpox and with CD4 counts less than 200, you should give it as it's prescribed, and you should not go for the intradermal route. Now, when it comes to ACAM 2000 vaccine, the important thing to note is this is a replication-competent vaccineovirus. So we would not wish to administer this to people with HIV at all. So they shouldn't get the ACAM vaccine. To sum all of this up, people with HIV have been disproportionately affected by monkeypox. It's not clear why this is. Is it because they have better access to sexual health and HIV services, in other words, an ascertainment bias, or is there something biological going on? Or is it related to sexual practices? Hard to know. In the US, increasing proportions of cases have been identified amongst Black and Hispanic and Latinx people, who we know to be disproportionately affected by HIV. In terms of outcomes for people with HIV with good CD4 counts, these have been similar to people without HIV, but of those with severe manifestations of monkeypox for whom the CDC has been consulted, majority have had HIV with CD4 counts less than 200, indicating substantial immunosuppression. So that's why people with HIV should be prioritized for treatment. So what I'm going to do now is I am going to bring in my wonderful co-faculty at this point, and I'm going to ask you a question that's come up. What do you think about monkeypox, Monica? Do you think that it is an STI and should be considered as an STI in this context? I'm going to go right in with controversial question.
So this has been an active debate. And, the way that I think about it is I don't actually find it stigmatizing to say how a infection is spread the majority of the time. I find it actually empowering, because then you can direct resources, especially limited vaccine resources, as we started towards that community. So I have sort of a different approach, but I did write a piece with others and about reclassifying monkeypox as an STI. And I'll show you the piece here, but it had to do with the fact that if you think about herpes and syphilis, by the way, healthcare workers could always get it, though they were mostly spread sexually. Healthcare workers could also always get exposed to herpes and syphilis through touching herpetic or syphilitic lesions. We didn't use to glove during examinations, for example, and now we do, but there were a lot of syphilitic lesions in healthcare workers. So there is rare other types of contact, which would be explain the monkeypox cases in children, for example, cuddling or close contact. Same thing with molluscum contagiosum, a pox virus. So all of that is that there are other STDs that are spread mainly through sex, but can be spread through other means. And the piece that we wrote, including with Gail Boland, who is former head of the STD division for the CDC, said that we think we should reclassify monkeypox as an STD for those reasons.
Yeah, I think it's an it's an incredibly helpful piece and really thought-provoking, and I completely agree with you. I guess the counter argument that I've heard is that it takes into account a narrow view of what an STI is.
Yeah.
Okay. And what people have said, the counter argument is, from that I've heard, I'm not saying it's my argument, that viruses have been found in semen, and you can find virus. And the question is it replicating? And that is the focus if you're going to consider a sexually transmitted infection to be an infection that is spread via sexual and bodily fluids transferred during sex. Now, I agree. I don't think that's the case. But I think in the beginning, that was very unclear. I know that in our case series, we found that of 32 people in whom semen was tested, 29 were positive for virus in the semen. But then there was the question, is it replication competent? And then that was picked up on by the Antonori group, who showed that in a single person with HIV, it was in fact replication competent. And then it was subsequently demonstrated again by Davide Mascesi's group.
Yes, so here's the paper here, by the way. just for all of us on the call, that this was published in Eurosurveillance. Like you just said, this is a piece on essentially looking at from May to July anal and urethral swabs. And the important thing is PCR can always reveal viral presence, but is it live? Is that virus live? And essentially the isolation here was a viable monkeypox virus from anal and urethral swabs in gay men with monkeypox. So I think that is very suggestive, as opposed to just shedding, the word shedding in semen. And I think that's important because we keep on saying close skin to skin contact, but if we said sex, it would probably, I don't know how much would change, but it would probably bring resources to it that are in STD clinics. Let's admit that where we've been seeing this outbreak, this started on May 2nd. We were overwhelmed really in many STD clinics, not in routine primary medical care, but places where people went in for sexually transmitted infections. That was really the places that got overwhelmed. Would that help us with staffing in those places and the expertise? So I think there are reasons to do it, but yeah, I think this is helpful information.
I think that we are too narrow in our considerations. And I think that our own sort of moralizing as a society against the behavior of sex, which is actually something that everyone does, otherwise nobody would be born in the world. It's become such a moral issue. It's always been a moral issue since the pill came out. It was a huge deal. That was a huge moral issue. HIV has been a moral issue. PrEP has been a moral issue. Now monkeypox. And I think people are worried about, for a lot of people that have looked after people with HIV, we remember what it was like with the sexually transmitted infection, HIV, and how the terrible things that happened societally.
Yes,
I think people don't want to say sexually transmitted infection, but actually I think maybe we just need to accept that there are viruses which are transmitted sexually, which can also be transmitted, as you say, by touching something like a chancre or a whitlow, and syphilis and herpes can be transmitted as a whitlow. They don't have to be sexually transmitted. And actually, exactly. And one of the pictures that we had in our NEJM publication was exactly, it looked like a whitlow. That's what it looked like. It was a finger.
From touching.
So
from
touching. Yeah. So I think we just need to be a bit wider in our thinking. And the Swiss, interestingly, the same people who wrote this famous Swiss statement have also written a statement,
which was undetectable, which was untransmittable way before anyone else did. Yeah,
way before, and they have said monkeypox is a sexually transmitted infection.
Yeah,
so we just need to listen to what the Swiss say, don't we?
Yeah, yeah. I think so. And so, and then the other reason is, we should expand eligibility and actually have of the vaccine, which we'll talk about next, to sexually active individuals, meaning. Very recently in San Francisco, we sort of said it's not just for gay men who have sex, it's really for those who are sexually active or qualify for PrEP. And so if you think about in the United States, who qualifies for PrEP, there are very kind of distinct criteria that have to do with sexual activity, but it really is about 1.2 million people should be on PrEP in the United States, plus 500,000 or so men living with HIV. And then that's the group that now is being tailored for the vaccine. So that targeted messaging, I see no problem with targeted messaging. In fact, at the beginning, remember the CDC was putting on masks in planes for monkeypox. It just creates panic. Many newspapers like New York Times was writing, school is starting, this is going to be a disaster with monkeypox. I mean, these aren't helpful. We called that misinformation actually, but that isn't helpful to spread panic in that way. You know how it's mostly spread, then you tailor your messaging, your resources, your vaccines, your treatments to that group.
Absolutely. Good public health is directing public health intervention at the people who are at risk and warning them that they're at risk so that they know how to protect themselves, and working with them to talk about what interventions will be most helpful for them. But firstly, they need to understand that they're at risk. And interestingly, we did a survey in the UK on public health perceptions of the public health messaging and media messaging in the UK.
Yeah.
And we have this, as it's been accepted for publication, but it's actually up there as a preprint. And we found some very interesting findings, very, very interesting findings. in terms of how people who are at risk perceive that public health messaging, including things like the fact that people were advised in the UK to go to sexual health clinics, but only 60% of people got the message they should go to a sexual health clinic. That was the key message that was given. People didn't understand where the virus came from. They didn't understand the virus originated from animals. Only 60% agreed that they would isolate if they had monkeypox. And very alarmingly, a large proportion of younger people said that if they had monkeypox, they would go nowhere. But fascinatingly, and this was well before there were any options for vaccines in the UK, it was a very early survey, 86% of those people who were surveyed said that they would accept a vaccination. And they were a group of, the group that we targeted for the survey were actually people who were at high risk, and we used Grindr and various other dating apps to access people. So it was interesting outcomes, really.
Yeah, and I think then that leads us to the discussion of the vaccine, because it is probably a good idea to talk about the vaccine, because the difference between COVID and monkeypox when it first hit, so monkeypox May 2nd was the first WHO case report, and then July 23rd, the WHO declared it a global health emergency, was that we had for monkeypox a pre-developed vaccine. It wasn't actually for monkeypox, it was for smallpox, but they're so closely related. As you said, the orthopox viruses are really just monkeypox, smallpox, cowpox, and then vaccinia virus. These are only the 4 tiny little family of orthopox viruses. And smallpox has been eradicated since 1980 per the WHO, in 1970, essentially in the US. And so this vaccine is extremely effective. The vaccines that we had for smallpox is really effective. And the main reason we knew that, as shown here, is that, well, there is the AKM 2000, and then there's the Jynneos vaccine, both live vaccines, but Jynneos is the one that we've been giving out in the context of this outbreak, just because it's more well tolerated than the other. But though there were kind of 2 studies that showed this, these are old studies, like you said, but this was one published from the now what's called the DRC, and essentially kind of took people who had scars from the smallpox vaccine, assumed that they had smallpox vaccine, and then said that there was an 85% protection, very wide confidence intervals, from monkeypox. That it was, it had its limitations as a study. I think this PNAS paper is the best paper that kind of indicates why we continue to think, and I think we've proven it, that smallpox vaccine works so well for monkeypox, which is just fundamentally, if you eradicate a virus, you stop mass vaccination programs. So that mass vaccination programs were stopped in West and Central Africa around the late 70s and 1980, and then give it essentially a generation where no one has any immunity to monkeypox or to smallpox. And then when we started seeing really the endemic outbreaks of monkeypox, like you said, it's in the rodent population in West and Central Africa, was essentially 30 years later. That was really the outbreaks that were occurring the most. So by definition, ecologically, smallpox vaccine protects against monkeypox. And then why have we seen this? I mean, we have seen this. Essentially, there's no doubt that over the context of this outbreak, starting around the 3rd week of August, there's been really a kind of precipitous drop in cases, kind of starting with the places like the UK and Europe where started first, precipitous drop in cases. Same thing in the US, I think for 3 reasons. One is, of course, remember smallpox used to give us natural immunity for life if we got smallpox. Are we getting monkeypox natural immunity in the populations most affected? Second is, I think, the rollout of the vaccine. And the third is also there is behavior change when there's a new STD, and cutting down on sexual partners. And so that's where we are. We're definitely seeing these cases drop. It's making it harder to enroll in some of these clinical trials, which we'll talk about next, for treatment. And then here in the US, we've given out more than 500,000 doses of the vaccine. So we're now on to our second doses, meaning it's 1 dose and then 4 weeks later, a second dose. We gave it intradermally. That was really pushed by the administration here. Remember, intradermal administration of vaccines in times of vaccine scarcity has been recommended by the World Health Organization for many vaccines. Not that it's been studied for Jynneos vaccine, giving it intradermally versus at a smaller dose versus subcutaneously at 5 times the dose. But it's been recommended for other vaccines because the intradermal space has so many antigen presenting cells. So in other situations, other vaccines, you can give less. So we've been giving 0.1 mil of the vaccine, of the Jynneos vaccine intradermally as opposed to subcutaneously. And as we referred to before, I think probably at least everyone who qualifies for PrEP in this country should get which is 1.2 million, at least in the US, should get the 2-dose monkeypox vaccine series. And then every man with HIV, given the information that you gave, and that's around 648,000 men, about this proclivity with HIV. We've never had an orthopox virus and HIV temporally coexist. Smallpox was gone the year before we saw the descriptions of the first AIDS cases in 1981. So we've never had a time temporally where an orthopox virus and HIV have overlapped. What kind of interactions do they have until now? So I think everyone with HIV should get this. And so maybe we can
just to stop you there,
yeah.
Monica. Somebody has actually asked the question around vaccinations and what are the guidelines. So I'm really glad that you have just covered the guidelines and when, certainly in the US, when a vaccine would be offered. And I think for the UK, it's pretty similar. It's people who are at high, who've had, multiple infections in the past few months. Anyone is a candidate for PrEP, HIV, and we started off our vaccination effort by offering it first to people with HIV with low CD4 counts. So we actually offered those people the very first appointments and then rolled it out to everybody else who's at risk. And I think one of the controversial issues has been, should we be offering it to other people who may be at high risk in dense central networks, which are not gay and bisexual sexual networks, such as commercial sex workers. And I know that there was questions around whether that should be the case. And I think that up to now, we don't have a lot of data on monkeypox in women. And I think hopefully that will change.
Yes, I think you'll change that because you had to do quite a wide search, right, to look for, across the world if women are so much less affected than gathering those cases and then describing that to us. Case series are extremely important when there's a new outbreak. Your New England Journal paper was very important, and then so was the CDC MMWR article that really got into more patient, about 2000, so that we could really look at the HIV association. So I mean, there are other questions in the chat which I think are important. Someone asks, the guidelines, I will say, for vaccinating someone who's had monkeypox just changed in San Francisco. So again, anyone who really qualifies for PrEP, multiple sexual partners, we also have opened it up in San Francisco to healthcare workers who are likely to see a lot of patients with monkeypox. I can't say I've seen that much uptake because our cases have gone down among healthcare workers, but there was a lot of interest from healthcare workers early on. And then Michael Hodges asks, be mindful that in many communities in STD, there's a stigma, so calling MP STD in order to access STD funds may not be a good justification. It's true around the stigma. On the other hand, it kind of, I sort of think of it in the way that I thought of COVID, that those who are most at risk needed most of the targeting for boosters, for example, older people, or for really helping with what was happening in nursing homes, for example. Like, it is good public health to target towards those who are most at risk. And even that one thing about STD clinics is there can be an anonymity to it when you come. At least in our municipal healthcare STD clinic, it's funded by the city. You don't have to give your name, you just come in and get treated.
Yeah, no, I agree with all of those points, but I think it's an astute observation, and I think there's pros and cons.
Yeah.
And I think what is important, what's very clear, is that across the world globally, people aren't only presenting to sexual health clinics, and that there does need to be an awareness of general physicians and everybody about what monkeypox looks like, because people have presented in dermatology clinics, in neurology, colorectal clinics, they've presented to ED, they've presented in primary care, and they've been misdiagnosed. Many of the people who we described in the case series, this had been going on for 10 days before anybody realized what was wrong with them, and they've been treated for all manner of different things, between chickenpox, shingles, like honestly, you wouldn't believe, syphilis obviously was a key problem, herpes, whatever, but I think it's important to recognize this. And I think on the subject of vaccination, it is really important to say that, you and I are in really fortunate positions in that we live in countries where we've been able to offer vaccination. And it is really upsetting that there are many parts of the world who do not have access to vaccines, as has happened in COVID. The myth of the interconnected world that everybody trotted out during COVID has been shown to be a myth, but it's now been shown that we've learned nothing from the first pandemic, and that actually in resource limited settings, particularly countries that were historically affected by monkeypox, they don't have any vaccines.
They are justifiably so upset.
Angry.
Because it is amazing that we didn't just learn from COVID, we didn't learn from HIV. I mean, HIV was the first state that taught us that antiretroviral access globally was first concentrated in the US and Europe in the late 90s, almost the entire first half of the 2000s. And then, there was attempts made through PEPFAR and everything else to get better access worldwide. But it is very tragic, because the thing about infectious disease epidemiology is we can maybe eliminate it in the UK and Europe and Canada and Australia and the US, but it is in animal populations, rodents, mice, rats, other rodents in West and Central Africa. And so vaccines will be needed because there will always be an animal reservoir. So vaccines are very important for that setting. We had just destroyed 20 million smallpox vaccines in the US prior to this outbreak, because it is still given out to a certain population, that's the military, for smallpox. So because of bioterrorism concerns. So it's not like we didn't have it. So there's a lot going on right now about COVAX with COVID-19. What happened? And it has a lot to do with greed. And so, and that's a very good point. It's making us all real. So maybe we could, do you think that we should turn to treatment?
I think we should turn to treatment. We've put the world to rights in terms of everything that's wrong with our world. So I think we should turn to treatment. Yeah.
Okay. So, I mean, I think we have a couple of slides here, but, there is, the thought that there'd be an antiviral for an orthopox virus, a DNA virus, there are some antivirals that have come up. And the one that kind of came up before this outbreak in 2022 was brincidofovir being kind of an old herpes DNA virus antiviral, and then tecovirimat. And there was essentially some pre-existing data about these medications. Let's turn to tecovirimat prior to using it and what we're doing right now. Let me actually go ahead to what we had before 2022. Actually, I'm so sorry. I may not have this slide here, but there was essentially some look at it in the case. Well, number one, we don't have any smallpox. So why would we use tecovirimat? Well, we are giving out smallpox vaccine to certain populations. At least the US military all gets smallpox vaccine. And if you give a live vaccine, you can get eczema vaccinatum, or you can get essentially especially if you have skin conditions like eczema, you can get a vaccine reaction that's quite severe. And so there was a paper about those who had eczema vaccinatum reactions that I don't have on the slide that we've used tecovirimat for. And then prior to this outbreak from 2018 to 2021, there were UK residents. These are all immigrant, people who returning travelers essentially from West and Central Africa, who 4 had acquired abroad, and then 3 got spread in the UK. And those 7 UK residents, of those, there was treatment with 1 of them with tecovirimat, 3 of them with brincidofovir, and all got better. Now, the natural history is to get better, but there was at least a attempt with the tecovirimat to look at viral shedding, and there was a shorter amount of viral shedding compared to those who didn't get tecovirimat. So that's suggestive. And then during the 2022, this May 2nd to now outbreak that's going on, we have had the ability to get tecovirimat. We have to get it outside of a clinical trial, which we'll talk about. We had to get it through kind of paperwork to the CDC for an individual, an IND, essentially an individual application for each patient. And then in your series, it looked like 2% had received tecovirimat. So, I mean, there's too few for, I think, for you to compare it. And then other kind of 2022 clinical studies that have been looked at, there was a CDC MMWR case series that we had talked about before. And of those 549 from May to August, it got tecovirimat because we had this emergency authorization IND protocol. And of these, 9.5% had vaccination as well, and 50% were HIV positive. People were definitely concerned about that, wanted to give maybe this population that more. And then median time for tecovirimat start was 7 days. And then the results are shown here. And essentially those who got tecovirimat, the initiation to the drug to improvement was 3 days. And 90%, at the end of the tecovirimat dosing had lesions that were crusted and healing. So that, I think, is, again, it's kind of hard to compare, right? Like there isn't a direct comparison in those who didn't get tecovirimat in the natural history. It will eventually improve. So what they ended up making a conclusion of is it was safe, which is a good thing if you're going to study it in a clinical trial. But the case series didn't feel like you could give a strong number, especially in this observational study, on effectiveness. And so finally, that is why we are trying to study it. Both the UK and the US are doing randomized clinical trials, the gold standard of figuring out if a drug is effective. We are absolutely still giving tecovirimat in compassionate use if any of these conditions are there near the eye, causing a lot of pain, severe pharyngeal or rectal pain, lots of lesions, rapidly progressing lesions, or someone who's immunocompromised. The rare deaths have occurred in these populations. But otherwise, the US study, at least, is the STOMP study. It's called the ACGG A5418 study, and it's truly randomized. It is taking people with lesions, ensuring that they have MPX by swabbing and looking at PCR positivity, and then randomizing to tecovirimat versus placebo. And we're enrolling. Our cases have gone down, so it's a little harder to enroll, but we are happening. This is happening. So
yeah, thanks for mentioning the UK study as well.
Yes.
So in the UK, the same group that led the recovery trial, which found many very groundbreaking findings during COVID, are running the platinum study. And that's sort of the equivalent to the STOMP study, and it's very similar. And I think, like you, we are finding it difficult to enroll because the numbers have gone down. I mean, I think one thing I would say, I think this MMWR report is really helpful. One thing I would say, though, is what's really difficult for me to understand reading the paper is how far into the disease different people were when they received tecovirimat, because of the diagnosis and misdiagnosis and turning up and whatever. And, I guess it really depends when in the illness they received it, in terms of, whether they, because it is as you said, it's a self-limiting illness. And I can understand why they felt that they had to qualify the comments on efficacy, because it really depends on at what point they received it. Although it does sound as though, anecdotally, from people that I've heard who've used it, it sounds as though it's helped those people. And certainly in this data set, which is by far the best thing that we have, it looks promising.
Right. Exactly. Perfect. Yeah, it does look promising. And I thought that viral shedding data, one patient, but it was important. And then, of course, we had, which I didn't mention, preclinical data, animal data on tecovirimat. So there are some questions that are coming up that I think are really excellent, because Christiana Oprea, I think, is in a setting where it's hard to get it. So HIV infected, someone living with HIV, good CD4 count, undetectable viral load, but a very severe extensive form of MPX with actual necrosis in the genital area and continuous replication for 4 weeks, lesions of the eye, but no tecovirimat, no cidofovir, no IgG, which we didn't mention, but that certainly was used before for smallpox, pooled IgG from vaccinia. And so, you talked about therapeutic vaccination before.
Yeah, I guess this person's well into the treatment. And I'm not sure. I think Christina's in Romania, I think. Christiana's in Romania. So, I mean, I don't know whether they have access to vaccine. I mean, many people don't. I mean, it's difficult. I've been contacted since, I mean, Christiana, I hear you, and I'm so sorry. It must be really distressing
Right. Yeah.
not to be able to offer therapy. And thank you for sharing this situation, because it's awful. And I've been contacted by physicians all over the world in similar situations, with very difficult situations, particularly with people with HIV, with thousands of lesions, as has been described, you know, in countries that have historically reported monkeypox, you know, very sick people on ITU with pneumonitis and all manner of problems, with no treatment. And I guess you just have to offer the best supportive treatment that you can. And I'm sure you've involved an ophthalmologist to provide the best supportive treatment for, you know, eye lesions that you possibly can. And, you know, in terms of the other disease, I mean, a really difficult, and necrosis in the genital area. I mean, that's a lot of the cases that I've seen have actually had genital necrosis, you know, in terms of the case series, what was reported to us. There were many cases of genital, you know, images of genital necrosis. It does appear to be something that happens.
Yes.
I mean, you know, one of the things that I wonder about is about exchange of knowledge, because, you know, it's all very well for us who've been, you know, thinking about monkeypox, you know, as clinicians since May. There are people who've been dealing with this, you know, since the 70s, with an enormous amount of experience. And I think, you know, potentially we should be doing more to harness, you know, potentially some sort of a network with people that have had, you know, decades of experience of looking after people with monkeypox. And I think maybe it's something we should, you know, I know the CDC is providing an advisory service, but I wonder how we could harness the knowledge of, you know, people who've managed these situations. In terms of guidelines, management guidelines, the Nigerian guidelines are by far the most helpful. Nigerian CDC guidelines, you know, prior to the outbreaks, they were very helpful descriptive guidelines. So I guess that might be useful, actually, Christiana, to have a look at the Nigerian CDC guidelines, because they're quite helpful.
Yeah, I mean, beyond the fact that they've had this long experience, I mean, I also thought about that with South Africa and the great work they were doing during COVID and all the genomic surveillance, and how Omicron was first identified there, and how incredibly important our colleagues have always been to us in sub-Saharan Africa for HIV. We work in tandem. The sexual transmission came out, meaning during this time of this outbreak, if you're in an area where there's criminal association with homosexuality, you're not going to report that there are outbreaks in gay men, or that this is looking like it was sexually spread. And so that really helped us during this outbreak, for Nigerian clinicians to come forth and say, yeah, there was sexual spread in 2019 of MPX. This is not unheard of, and not just from the rodent exposure. And that was incredibly helpful. But keep in mind how much you can't report if you have this situation. So yeah, I think the idea of having tecovirimat and vaccines in West and Central Africa is obvious. And we have to come back to that. And I hope that this will change.
So I guess there aren't any other questions that I can see in the chat, but I guess there's some interesting discussions to be had around monkeypox in general. And I think in terms of HIV, because I think most of this audience will be interested in HIV specifically, is, you know, there is this very clear, very marked association between, you know, these two infections, with a lot of people with HIV across all the cohorts being identified as living with HIV. And I've heard a lot of discussion around potential reasons for this. And I think that, I mean, I'll tell you what I think, and I'll be very interested to know what you think. I mean, looking at where people present, you see how many people have presented to the HIV clinic or the sexual health clinic. And we know that we offer testing in the UK. We offer testing every 3 months to people living with HIV for sexually transmitted infections. They're well connected to the sexual health clinics. They're well versed at looking whether they have lesions or something is wrong. To me, I do feel that at least part of this has got to be ascertainment bias, in the sense that people who feel confident accessing services are most likely to turn up. The disease can be mild, it can be misdiagnosed, it's self-limiting. You know, in Belgium and in France, they've reported asymptomatic transmission So, asymptomatic carriage in the rectum. So it's possible that people have got mild, very poorly symptomatic disease. So part of me thinks that ascertainment bias has got to be part of this
You
picture.
just linked into care. Yeah.
Correct.
Yeah,
Correct.
I think I was going to say the exact same thing, because we had two places in San Francisco where the cases were very high in July. And one was our HIV clinic, Ward 86, which is a low-income HIV clinic where I work. And then the other was the STD clinic. And we put out notices. I mean, we like told patients to come in. We told them this is happening. Ask your friends. Are they having any concerns? Come and see your doctor. We opened urgent care for longer because we were doing swabbing and giving out tecovirimat. We need to do the paperwork. So we kind of like welcomed the diagnosis, welcomed in trying to get people help for the diagnosis. So I think there was, as opposed to kind of passive drop-in the STD clinic. So I think it was different. And we definitely got, our population was definitely enriched for people living with HIV. I don't quite know how to make sense of the CDC data with the more rectal symptoms, because one thing they did not describe was were there more rectal lesions. They just said proctitis, more bleeding, more pain in that area. But because it was kind of observational and maybe they didn't have a good case report form about how many lesions, somehow there was that missing link. Is the lesions. Yeah.
Yeah. And I found that difficult because I think to try and square that with the data from the case series, which was large, 528 people with 41% living with HIV.
No difference.
We found no difference. But what we did find is of the most significant complications, there was an epiglottitis that was in a person with HIV, the only person with a CD4 count less than 200. And that person was treated with tecovirimat and had extensive lesions, was in intensive care. And then one of the cases of myocarditis, I think we were the first to report myocarditis in monkeypox. We had 2 people with myocarditis and one was a person with HIV. So I guess it's difficult, but I think the important point is that if you look at the Nigerian group of hospitalized patients that I described first, they found significant problems, but they had a largely, unsuppressed, low CD4 count, untreated population. They were very different from the population I'm talking about. And it wasn't only the global case series that reported no problems. It's all of the sort of case series in sort of Europe have all described no problems with well-suppressed people. But I think what's different is that this cohort in the CDC, only 82% were undetectable on treatment. Yeah. So there's 20%.
That reflects our national numbers. But
yeah, and that's right. So 20% were not. Yeah. And that means that's a large group. 1 in 5 of the people in the cohort were not the same as the NEJM group. They were more similar to the Nigerian group. So I don't think it's very surprising. And I don't think it's actually that much of a new finding. I think it's just that they were an intermediate cohort. Were they the same cohort, I think the findings would be similar to the other cohorts. Yes. And then I guess the question is it biologically different? Is the rectum in people with HIV different? We know that there are differences in microbiomes between people with HIV and also in MSM. And is there something biological that means that it's got some sort of affinity? I think that is a question which is well unanswered and way beyond, it's very speculative. My personal view is it's ascertainment bias more than anything in terms of why this is happening and why we're seeing this and access to services.
Yeah, I agree. Yes.
Yeah, you never want to be too dogmatic.
Yes.
You never want to be too dogmatic.
Targeting those with HIV for vaccination certainly makes sense to me. Why not? And the vaccine supplies have increased significantly. Again, not in West and Central Africa. We've talked about that, but the vaccine supplies have increased significantly over the last 2 months, which, by the way, I have to give the HIV community activism and advocacy from the HIV community so much credit for that, because there was such a movement. The same organizations that have always helped us have always known what to do during HIV. Really, we had protests, we had major advocacy, and things happened more quickly after that.
Yeah, I agree. Like, totally hats off to people and new activists that stepped up, people that were willing to go on Twitter and show their lesions. One of the patients who was treated at our center documented his lesion on his nose, awful lesion. He was very unwell. showed his own face, talked about how he was trying to help other people to recognize monkeypox, and has remained an activist. And for his troubles, he's been vilified on the national press for being gay and out, and having monkeypox, with sort of moralizing homophobia. But he's persisted and continued to be an activist. Now, somebody else has asked a question around saying that dermatologists recommend cortisone for lesions. So, Christiana, with some of the rectal lesions, some of the things that we've done is mesalazine. So like treating it as though it's IBD, because there's a lot of and then sort of aggressive bacterial coverage, antibiotic coverage, drainage where necessary. And I think with steroids, I would always be concerned about steroids in someone with a very low CD4 count because of the potential for, infection and sort of massive, reduction of the immune system. But I think certainly, things like mesalazine, drugs that affect the immune system have been useful for rectal lesions. I don't know if that helps.
I mean, one thing I would just add, we had a whole pain control protocol because there was significant pain, discomfort. It was really, we needed that. And so we did, I think that's a great idea. I really like that idea, Sal's, and we didn't have that on there. We used sitz baths, sitting in sitz baths. We used gabapentin at times because the pain was very often kind of neurologic or very sharp. We used opiates if we had to. We used Tylenol and NSAIDs. We used comforting like lidocaine on places. So we were very aggressive actually about pain control because it was uncomfortable.
Yeah. Yeah, absolutely. So, I mean, we don't have any further questions as far as I can see.
Right.
Was there anything that you wanted to say, Monica?
One thing I'll just add is that that the clades, have been renamed. The clade 1, it used to be called the Congo Basin clade, which is more virulent. It's now called clade 1, and then the West Africa clade, which is less virulent, and the one that's spreading is now called clade 2. And there's a very active movement to rename the entire virus infection. So WHO is taking suggestions, and many people are saying MPX or whatever they want to say, MPV, but we do have to come up with one name because I think that's like important. And, it was just a very historic, strange fact that it was in a lab accident. This has nothing to do with monkeys. It's not a reservoir. So that's one movement, something that's happening with this. And then I think that's it. I think we went over a lot of data and had good questions. And if anyone wants to ask anything else, otherwise we could give people a few minutes back.
We can give you 4 minutes of your lives back, but what I would say, in addition to what Monica said, phylogenetically, I think what she's mentioned in terms of reclassification is really important. The other thing to say is that the virus has changed more than what we would expect in 4 years, because it's an orthopox virus, a DNA virus. You don't expect a lot of mutations. You expect about 4 mutations per year. And what's been described is about 50 mutations, and many of them are in the APOBEC region, which suggests that there's been some adaptive immunity and that the virus has probably been living in humans for much longer and replicating, unknown in humans for much longer than has been realized. So I'll leave you on that depressing note. And one
practical implication of that, we've had a few cases, very few, of where the PCR did not pick up MPX because, we actually had a deletion in the PCR where the primers are detecting the virus. And so we had to send them out to kind of a special lab, and then we were able to diagnose it when we really thought. There's a few cases in California.
Yeah, that's fascinating. And I think it's important for us to realize, even when viruses we think can't mutate, I think basically we learned in COVID
mutate a lot less. Yeah.
I mean, what we learned in COVID is everything that we thought we knew. And at the start, we just need to be humble, and we need to learn and look and learn. And when things aren't behaving the way we think, we need to be open to the idea that, viruses mutate, things change. And, I think some of us have learned a lot from COVID.
Yes, too much.
So it falls to me to say it's been an absolute joy and a privilege and a pleasure, Monica, to do our first gig together.
You're so great. It was so great to talk to you. It
really was such fun.
Blazed the way with this, actually, in a very, that first case series was incredibly important paper. So thank you for your work on this.
Oh, thanks, Monica. And take care, everyone. Have a good day, afternoon or evening, whatever time zone you're in. And signing off now.
Thank you.
Thank you very much to Dr. Gandhi and Dr. Orkin, and thank you to our listeners for joining in. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.